Yeah, but like is uh, we will have a short recap because as that is what I was trying to find out, because about eight or nine people are also joining us today, so that in the best interest of everyone, what we will do, we'll do a quick recap of what we did yesterday for 10-15 minutes, and it may be a good revision also for all of you too. And then we will go into today's topic also. Just give me a couple of minutes to share my screen. Sinia, I will share from my end. If I have any difficulty, I'll ask you, okay? Can you all see my screen now?
Yes, ma'am.
Okay. See, we are just going to do a quick recap only. So I will take you through the slides which are essential alone. So basically, first, what is palliative care? As was explained yesterday, the verbatim definition is obtained from a Latin word pallium, which means to cloak or to cover. And the dictionary meaning, if you see for that, first, as I said, the other one is a Latin word. What is the true dictionary meaning? It is relieve without curing. So that is the verbal meaning for the word pallium. From there only, the whole thing has occurred. These are general statistics. I will just give you a gist of all this. Basically, what it says is, in today's world, the most common cause of disease is non-communicable diseases. So that is what is bothering the world to a very great extent, because very many years ago it was infective diseases which was causing the trouble, whereas the whole scenario has changed. And because of that, and the common non-communicable diseases are dementia, renal failure, cancer, cardiovascular, respiratory, every system you can take. And then, and the number is all what was like 61 million people is the statistical figure given who need this supportive care. And then it is, another thing is, it is long term, it is not for few days, it is for a very long drawn process. And last but not the least, death is inevitable, you cannot change that. But what has happened today, we also give importance for quality of life, and that is where palliative care has a role. And life expectancy has increased to a very great extent. That's the benefit of science and medicine. And what is definition? Palliative care improves the quality of life of patients and that of their families who are facing challenges associated with life-threatening illness, whether physical, psychological, social, or spiritual. The quality of life of caregivers improves as well. So in the definition itself, the patient and caregivers are combined. So as I mentioned yesterday itself, like I'll just give a overall, so far what I said in Telugu also. Basically, palliative care ante emi, అది ఎవరికి చేయాలా, ఎందుకోసం ఇది చేస్తున్నాము ఏమంటే 50-60 years ముందు ఇన్ఫెక్టివ్ డిసీజెస్, కాలరా, టైఫాయిడ్, అలాంటి డిసీజెస్ ఉండింది. దానికి ట్రీట్మెంట్ చేసేది ఎక్కువగా ఉండింది. ఇప్పుడు చూస్తే ఏం ఎక్కువగా ఉంది? డయాబెటీస్, హైపర్ టెన్షన్, క్యాన్సర్, డిమెన్షియా, ఇవి అన్ని నాన్ కమ్యూనికబుల్ డిసీజెస్ కేటగిరీలో వస్తుంది. దానికోసం అదే ఇప్పుడు ఎక్కువగా ఉంది. అది ఫిగర్లో చెప్పాను, 61 million పీపుల్ ఉన్నారు, ఫుల్ వరల్డ్ స్టాటిస్టిక్స్. అది అలాగ చూస్తే దాంట్లో మనము ఏం చేసి ఆ సఫరింగ్ ని తగ్గేదానికి ఏమన్నా ఉందా అని చూస్తున్నాము. దానికి పాలియేటివ్ కేర్ హెల్ప్ చేస్తుంది. తర్వాత పాలియేటివ్ కేర్, పాలియం అంటే ఏమి, కవర్ అంటే ఏమన్నా క్యూర్, అన్ని కంప్లీట్ గా సరిపోతుంది అని చెప్పేదానికి కాదు. అన్ని డిసీజ్ అలాగ లేదు. ఇది వరకు చెప్పింది పాలియేటివ్ కేర్ డెఫినేషన్ అంటే ఏమని. తర్వాత నెక్స్ట్, హౌ క్యాన్ దిస్ పాలియేటివ్ కేర్ బి డెలివర్డ్? It can be a home-based care or a hospital care. So both are possible. Both are equally good. That's what we will see. Is the person who started and brought this into effect. That was in 1967. And the next slide will show how it started and where. 1950s, initially, the awareness came. And in 1960, Kubler-Ross wrote a book on death and dying. And in 1974, a surgeon in Canada defined palliative care. And in 2006, from 2006 onwards, many countries have recognized palliative care as a department. They have got courses. In 2006 itself, United States started, like they have AB, that is the, like medicine, like you have gastroenterology, surgery, like that. They have palliative care as a department. And then in India also, for the last 5 to 10 years, there are at least 6 universities doing MD palliative care and at least 6 recognized centers for DNB. That's another form of obtaining degree or specialization. That so at least 10 to 12 centers are there where someone can get an MD palliative care degree in India also. Next, what are the fundamental aspects of palliative care? Main thing, it provides relief from pain and other distressing symptoms, affirms life and regards dying as a normal process. Intends, these are the important things. This is what was said yesterday in ethics. Intends neither to hasten or postpone death. Integrates the psychological and spiritual aspects of patient care. Offers a support system to help patients live as actively as possible until death. So these are the main goals. We are going to be, yesterday, as he said again and again, many times when there is no cure, then you think, okay, nothing can be done. So when you tell that, that is what affects or hurts the patient more. Okay, so what, you will not do anything. So that time if we say, okay, we cannot cure, but we can care, we can give support, we can be with you all along, make your rest of your life, see the last support system to help patients live as actively as possible until death. So in all this 5 days, no, some salient points will hit you. So those are the things which all of you have to catch and hold on to. And offers support system to help family cope with the patient's illness and in their own bereavement. So that's what palliative care doesn't stop just with patient. Bereavement care also is part of it, and uses a team approach to address the needs of patients and families, up to bereavement counseling, etc., and will enhance quality of life and may also positively influence the course of the illness. So the course of illness is from diagnosis till death. The whole thing is there. So palliative care will help all along, which I will show in a diagram, in a pictorial way, which was shown yesterday also, how palliative care and curative care can go hand in hand. Generally, life-threatening illness, it may be cancer, neurological, respiratory, or cardiac. Any of the things mentioned on the left side can have all the things mentioned on the right side. For example, if you take cancer, it can have physical, like something in the face can have a physical change. Social, it's a stigma. Psychological, the patient gets affected. Oh, I've got cancer, they're scared. Then spiritual health. Oh, what did I do wrong? Why am I punished? Then it can have impact on the patient or the family. So both patient, or not only or, patient and the family. It can be or and any word you can put there. So one problem has so many impacts. So that's what is mentioned there. And then individually, we have seen, we'll not go into every detail, we'll see some, because as you all start working, you will know. Physical aspects, it could be pain, nutrition, weight loss, infection, like incontinence, bladder bowel losing control, then shortness of breathlessness is a common problem, or shortness of breath, nausea, vomiting, then pressure sores. If someone is lying on the bed for a long time, they can get pressure ulcers, pressure sores, wound. That is all. So how are we going to manage this? Managing it in a team approach. See, just the doctor, that is what we normally say. You need a doctor, and then you need a nurse to do the dressing every day. And then you need a social worker to tell them that this can be managed, not to be upset. They're teaching them how to do. We teach a lot of things to the carer because that is what is important. Carer may not know everything, but you have to impart that knowledge to them. And then communicating with families, using the psychologist and things, which we will come through. So multiple aspects are there. And then see, when you communicate with families, we also teach them or tell them what happens at the time of death, and helping them to come to terms with that, with the situation, and once they know to anticipate what it is, and then they will spend their precious last few months with the dying person comfortably, rather than repenting later on. లైక్ నాకు తెలియదండి, తెలిస్తే నేను చేస్తా ఉన్నాను, ఇప్పుడు ఏం చేసేది, వాళ్ళు ఇప్పుడు లేదు, ఆ స్థితి రాకుండా ఉండేదానికి ఏం చేయాలా, అది కూడా మేము వాళ్ళకు చెప్పేదానికి వస్తుంది. అలాగ చెప్తే ఇది ఇలాగ చెప్పారండి, ఇప్పుడు నుంచి నేను ఇలాగ చూసుకుంటాను. సో దీస్ ఆర్ థింగ్స్ ఈవెన్ ఇఫ్ దే డోంట్ నో, వీ కెన్ టీచ్ దెమ్. సో దట్ ఈస్ వాట్, with the physical aspect, from physical aspect you can go to the psychological aspect also. So psychological and spiritual, as I said, emotion, fear is one of the common things. Why fear of the unknown? What will happen to me? How will I face this? As was said yesterday, many are not scared of death, but they are scared of how they will die. See, to some extent everyone will know that everyone born has to die, but how is my death going to be? Is it going to be painful? Is it going to be distressful, or is it going to be traumatic? సో దట్ ఇస్ ఎలాగుంటుంది, అదే అందరికీ పెద్దదిగా ఉంటుంది. సో మీరు ఎలాగుంటుంది అని చెప్తే వాళ్ళకు ఫియర్ తగ్గిపోతుంది. సో ఫియర్ ఇస్ ద ఫస్ట్ వన్, దట్ లీడ్స్ టు డిప్రెషన్, అండ్ దెన్ దట్ లీడ్స్ టు వర్త్లెస్నెస్. అగైన్ వర్త్లెస్నెస్ అండ్ గిల్ట్. Worthlessness, oh, okay, now I can't do anything, I need someone to do everything for me, I need help for sitting, bathing, doing my day-to-day activities. Next comes guilt. Oh, I did something wrong, that is why I'm going through all this. So no, we can tell them everyone goes through it, no? So each one there only the spiritual element may come. So based on I'm linking from one to the other. See, from spiritual you can also connect the cultural basis and needs. Each region has a different way of approaching things. We have to respect all of that. Okay, and this can be addressed the above with the help of multidisciplinary. See, one doctor alone cannot deal with fear, depression. So there your psychological team, you in some hospitals there is a separate psycho-oncology team also, so they can be of help to you. Okay, next comes spirituality, spiritualism. For that also we have assessment, and many studies have shown if someone has a spiritual belief and background, they deal with these situations better. Because what is spirituality? Meaning of life, purpose of life. Religion and spirituality is not the same. As we go through, if we get a chance, I will explain about that also. Spiritual support is associated with better quality of life because many studies internationally have proven that. So that is why when you see about pain or anything, we say total, which has physical, social, psychological, emotional, and spiritual. All these four only together make something complete. Okay. Religious and spiritual practices can help the cancer patients and their caregivers cope better in terms of distress associated. So you allow them to follow their spiritual and religious beliefs. What is the aim? Is to support, enable a dignified death. So these are the core principles. Barriers of palliative care and all, as you go through, you will know it. Barriers can be from professional, organization, national health policies, scarcity of resources, scarcity of people. Other barriers are like people not knowing. Many don't know what is palliative care, and they have cultural and social barriers. Like, for example, some place they may think everyone, if they have done something wrong, they have to struggle. That may be the cultural thing. And that is where volunteers and others can be helpful. They can say, okay, we will follow your belief, still we can help you, so you can have a better quality of life until your life. Okay, cultural and social barriers such as beliefs about death and dying also has to be considered and taken. And individually, and WHO recommended everyone needs to get pain relief. What they feel, even though they have been telling this for many years to all countries, still delivery of the drug to the patient is where they're finding difficulty, because what they feel is they are able to make the drug available, but that drug which is available is not reaching the patient. So drug delivery is where they are having the some extent. That is true. Even in India, see, now morphine is available, but is morphine available to every patient in every? That's where the trouble comes. This hospital.
Ma'am, please, sometimes
does someone want to ask anything?
Senior here, ma'am.
Oh, is my voice breaking?
Yes, your voice was breaking a bit. It's okay now.
Is it better now?
It is better.
Okay, 1 minute. Oh. Okay, like if there is 1 second here, mine always going back, this doesn't do. I want to go back to that. Sorry, I will go to the end and only have to come back. Okay, can you all see this clearly now?
Yes, ma'am.
Am I? Okay. See, this is what an important thing to understand. Palliative care and disease modifying therapy, or curative care also you can say. See, from the beginning, that is leftmost point where presentation diagnosis there. From that time itself, palliative care and curative care, if they work together, initially curative care, they may have surgery, chemotherapy, radiotherapy. So in that part, see, first phase, the curative has a bigger role. The white element is more, yellow element is less. As the disease progresses, they may get to a stage where their treatment is not being beneficial. That is when palliative care increases. As was told yesterday, if curative care is going to be very good, and then palliative care may not be needed. That also is possible. See, for example, breast cancer, many breast cancer patients live now for 20 years, where it's become like very common. But there may be still some breast cancer patients who may have, see, triple negative. There are so many types, subsect. When you see, they may have a bad prognosis. So that is why we are telling we cannot label anyone as one particular type. So according to each patient, you will have to see what is best for them and then move forward. So that is what is mentioned here. So then if the disease progression is more, then the palliative care role increases. Then if need be, they are very sick, the element of hospice care comes. And then after the death of the patient, bereavement also becomes part of it. So the first part is illness, next part is bereavement. Okay. And then the common problem what is faced is pain and breathing difficulty are the two common physical symptoms which needs to be taken care of. And for that, there are medicines available now which can be used. So in next few minutes, we'll finish this and go to our, basically, palliative care can be hospital-based care or home-based care. What are the benefits of each is what we are going to see. Hospital-based care, varied setup from outpatient, inpatient, daycare, everything will be under one roof. And all teams, physiotherapy, psychology, their cancer team, palliative care, everyone will be in that same hospital. So that is a big benefit. Nurses will also be there, wound care. If need be, you can admit them, treat something, and then send them back. So all available in one place. Whereas home-based care also has its advantage. It's a form of palliative care that provides all the basic needs, physical, psychological, moral, everything, to a patient who is suffering from the disease. It can be done at home. Is why? Because it is done by a trained multidisciplinary team. You're not going to send someone who is not trained. So the thing is that this team of doctor, nurses, social workers. See, every team, it depends on the availability of manpower. So every team may not have all of them, but how they will do according to the need of the patient, they will send. So, for example, if you take Pallium, they have 7 home care teams going every day. So they will have, for example, team A has going to see 6 patients. In that 6 patients, what they have someone who needs some social support and physiotherapy that day. So they will have. How all these are possible? Because of volunteers. There are some areas, there are volunteers who will have information of all the patients. So they would have told, oh, this patient needs physiotherapy. So that home care team will have a physiotherapist and a social worker. Whereas another team has very sick patient. So they need a doctor definitely in that team. Whereas this team, which I said, who need more of social worker and physiotherapist, if there are no doctor available, if you have only 2 doctors, you send the doctor to the patient, to the team where the need is there. You use the resources wisely. Okay. And so in this also, care is provided in par to one received in hospital. That's the important thing. This is slightly little more information about why is home care important. See, first is from patient's perspective and from carer's perspective. From patient's perspective, if you see, any one of us also will be happy when we are at home. So it gives peace of mind when he dwells in the peaceful environment of his own home. Everybody wants to have their loved ones near them, and that gives confidence when he's getting the treatment at home with the family members, and they are also taking part. So both the patient and the carer both are happy. And from carer's point of view, you see, they want to look after their loved ones, so they will learn from you. We can teach them, and they'll be happy that they're able to do. It helps in the physical, psychological, financial well-being. Hospital payment, or see, if it's a nursing thing, if it can be done at home, the cost also is covered. They're happy that they're able to do for their loved ones. So home-based care ensures continuity of care for patients and empower the carers in the family by teaching them simple, cost-effective methods. As I do the communication element, I will tell you also what simple methods can be taught. And last few information is, how can you do all this? Is by providing education, communication, telling them what are the behavioral and communication changes that can be made, and all that can be a great can play a great role in the success. So with this, we'll complete this and go to our today's presentation. Okay, Sinya, can we come out of this presentation so that we'll just ask them if they want anything, and then I'll start the second one. One second. Hey, anybody wants to ask me anything before we go ahead?
Madam, can this lecture be transferred to somebody who is already suffering for want of palliative care? Patients also can undertake this training to live better.
No, we are teaching you. You will become the training person.
So we can train the same matter what you are telling to the patient also. Am I correct?
Yes, that's what is the role of you.
I see. Or they can also participate now in the course.
No. We don't.
We don't advise.
You have to see. Basically, we are like slowly with your doctor team and thing. You do that job. I can't, what, like we can't have 500 patients attending this course, no? Like, everyone will want to bring the patient. See, no one should get think that I'm acting out at any. No, everyone will want. So that's what. See, that's why we go this as we call Palliative as a training model. We try to teach you so that you can do that element from your point of view. Is that clear? Have I made it clear or?
Ma'am, we have to keep your video off, I think. Your network
Okay.
was.
It might be. Yes. Correct. Could be. Yes. I don't mind because all of us are here. No? So, is it, Sinia, you keep an eye on it. You tell me if my voice is breaking, let me know. Is it better now?
Yeah, it is better now.
Okay, we'll keep the video off. Good, dear. So, is it clear? It was Chalapati Kora. Is that clear what I explained? Okay, that's what not. See, all of you, with the help of your doctors and other team, you will be able to do the same thing. Not somebody has mentioned, can a patient with a life-threatening health issue attend this course? No. See, their tender loving care, you can't ask them to attend a course. No, that is where your nurse and social worker will play the role. See, I do understand this COVID has brought everything virtual, but still human touch, that love, care and affection is needed. If it was you, will you like say someone go see something, will you be happy with it? No. See, that is what, see, as volunteers also you can help. I will, as we do our session today, I will tell you how are the ways you can help too. And I do understand that you're this is one easy way. Oh, this course is there, they can attend and that might help them. In good interest, you are all telling, I don't deny. But that's what you all see. First thing, for example, 35 or 40, how many of you are here today? 35 of you are here. Okay, this 35 can become 350. How? You can talk to 5-10 people, and then that 5-10 every time, like monthly once, you can impart this. And then that easily 335 can become 350, 3,500, any number. That is what is possible. We don't think it's impossible. It is possible to a very great extent. Word of mouth, it goes a long way than what we anticipate. Both good and bad go like that. We will try and put the effort to spread the good rather than the bad. Bad goes fast. Good takes more effort. But all of you are so willing. Where there is a will, there is a way. So because you're all willing, someone who is willing, no, will be also willing to face obstacles. From the lot of you, some of you would have had obstacles to attend this course itself, but you would have overcome that to attend this. So that itself is the first positive sign. So if you keep on moving like that, you can be successful. That is the way forward. Okay.
Ma'am, I have
Anything else?
a question.
Go ahead.
Ma'am, I'm planning to start a care center, go to the homes and then provide care for the
May I
senior
know?
citizens.
No,
But
may I know what are you? Are
okay,
you?
yeah, exactly. That's why I don't have any credibility from the medical domain. I'm a software engineer. I was working with a company for last 20 years, and I have been, trying to come into the social sector for quite some time. Now I decided to, get into the taking care of the senior citizens specifically in my
No, but
locality.
for that you need.
Yeah.
But for that you will need a doctor and a nurse
Yes.
with you,
Yeah.
or at least a nurse.
Yeah, actually, I talked with people, and there are two doctors, one MBBS and the other one is an MD in internal medicine. They told they can
Okay,
join
for
me.
you, no,
Yeah.
I will talk to you at the end of this session. Your name is
Okay.
Prakash Matthew.
Yes.
Okay,
Yes.
I will talk to you at the end of the session. We will guide you and help you to move forward also. It's
Sure, thank you so
nothing is
much.
impossible. That
Okay.
is the attitude you should have. Okay.
Okay.
So
Yeah.
if is there anything else you want to ask, or shall we go for today's topic and then have the queries?
Yeah, we will go ahead with the today's topic.
We'll go ahead with today's topic and then.
Yeah.
Radha ma'am. Yes.
Hello, there is interruption, madam. Am I correct?
Kindly wait, sir. Ma'am is trying to share her PPT.
Okay.
Communication and palliative care. Sinia, if there's any break in my voice or something, you just have to tell me. Okay.
Sure, ma'am, sure.
Okay. So our topic for today is communication. Why? Because see, the important element of palliative care is how are we going to talk to the patient? How are we going to talk to the family and find out what is the most distressing thing and everything. So communication plays a very big role in palliative care. So we will see in detail about it. So good communication is vital. Next slide, please. So next comes, what is communication? It's a process by which information is exchanged between individuals through a common system. It could be with symbols, signs, or behavior. Next slide. So next, communication as such could be verbal, non-verbal, visual. So for this, I would say, we'll stay on this slide, Sinia. ఏమంటే మీరు మాట్లాడేటప్పుడు ఏం చెప్తారు, ఎలాగ చెప్తారు, అన్ని ఇంపార్టెంట్ అక్కడ. మీరు ఇది పేషెంట్ దగ్గర కాదు, మీరు ఇంట్లో మాట్లాడేటప్పుడు కూడా ఎలాగనే కదా. సో ఎవ్రీథింగ్ కౌంట్స్. సో దాట్ ఈస్ వై we have said verbal is by words, non-verbal is symbol. Just by the look of the eye, many times youngsters, elders, parents, children, your look was not right, you wouldn't have said anything. Okay, many times that comment comes. So what is that, a verbal communication? No, non-verbal communication also plays a very important role. Then visual, what you see stays in your mind for very, very long time. Normally, easy one I generally give is cinema posters. Okay, all of you see one cinema poster and tell the whole story of the movie itself. How are you able to tell? Because of that much impact visual communication gives. So visually you can communicate more. So everything has an important role. So verbal, non-verbal, visual, all three have importance in their own way. Next slide, Sinead. Hello? What is the importance of good communication? It helps you to connect with the people effectively, helps to know them and come close to them as sufficiently as needed, helps you to make them comfortable and gain their confidence. So that is the importance. Okay, when you say something, they should have confidence in you, and they should be willing to express their wish or concern, anything it could be. Normally, they will, anyone, not only patient, we will also not be willing to open up. As soon as you see someone, you, to the same person, you will open up when you have confidence through communication. You speak 2 times, and 3rd time you may open up and say. So like that, the same thing happens with patient, doctor, patient, nurse, or anyone. So that is why it is important to communicate properly. If your communication is not going to be right, you will not be able to deliver what you have to, and you will not be able to collect the information also what you need to. This can be from volunteer perspective also. By, for example, you have someone nearby to you who is suffering, but with your kind words, they may be willing to tell you something, and you could be of some help to them. So that is why good communication. If you were harsh or you were not talking properly, they will also not come and tell anything to you. So that is why good communication is needed. Next slide. What is the significant communication in palliative care? What is the significance of it? Because all issues are complex symptoms and situation management is needed. See, like for example, someone has a lifelong illness. So that itself is not simple and straightforward. Someone has a disease where they cannot walk. So that is not a common thing, no? So it is a complex situation. And then immediately, if it is complex, then management also is not going to be simple and straightforward. So most of the situations that you see in palliative care, they are complex symptoms needing management. And then difficult and different topics, sensitive topics. If it is cancer, you have to tell them what it is, not only for the doctor, for the nurse, or nurse to the patient. So those type of things are very sensitive, close to their heart, and life, deciding their life, further life, what is their, what's the rest of their life going to be. So they are all difficult and different topics. They are not straightforward, not like routine. For example, everyone in their routine life, for example, I would say every day you get ready, go to work or go to school. It is not like that. Their life is not a routine life. Their life is totally different. For example, someone has a disease where they cannot walk, means then every day-to-day activity, even personal activity, they may need help. So is that common? No, it is different and difficult also. So that is why the situation is not straightforward. So you need to communicate in a better way to convey, convince, and get their help to provide the service. So communication is of great importance. Next slide. What we say, communication is also a skill. What do we generally think? Oh, all of us talk, so everyone can communicate. It's a general attitude we have, but it's not so. What we generally say is communication is also a skill which has to be learned and practiced and taken care of. So we'll go through the rest of the slides to see what it is. Next slide, please.
One second, ma'am. I'll share it again.
Next one. So first important thing is non-verbal communication. See this picture. If you see this picture, see how the patient or person is, and then the carer or nurse or whomever you can take. See every aspect of the picture, eye to eye, the level, they are in level, and she's having a good smile. even if someone doesn't have as a routine habit to smile, we normally say, please learn to smile and develop that habit. Start doing that on a daily basis. There are many things. Smile takes you a mile. It is so helpful. There's no match to it. Even if someone is in, see, we are not, even if they are struggling or uncomfortable, a smile can make them also smile. Okay, so that is something which you can develop. Posture and position, see how they are. She is leaning forward, making sure that the patient is comfortable. So that posture and position is important. How? And eye contact. And next is personal space. See, going close to a person or patient depends on regional and cultural beliefs. See, everyone may not be comfortable when you go very close to them. For that, we say it's called as a personal space. You don't go into someone's personal space until unless you know them. So, but for example, this nurse, maybe she had known the person, and especially when you're as a nurse or a doctor, you go closer to them, only after getting their permission. All of us will do that. We will ask, are you okay? I'm so and so. Can I see you? When the person or patient says yes, we will do. Or if they're uncomfortable, we won't do. So get their permission and then do next. So in this picture, it is important. Everything counts. The way you see, how it is done at that eye level, because if you're not in same level, this hierarchy, I am big, you are small. So that type of thing will avoid someone to open up. So that is why every aspect, what you see in this picture is important. And that is what you have to do. Audio is low. Someone has said my audio. Is my audio low?
We can hear you clearly.
Okay, then that person, maybe you can sign out and sign back in. Sometimes that might help there. Okay, next slide, Sinia. Next thing is active listening. See, in listening, there is two types. One is just listening and next is active listening. This active listening is important because passive listening or just listening can be very, I'll give you example. So two people may be talking, one person may be talking and the other person may be on the mobile phone, seeing the mobile phone. That is not active listening. Simple example I'm telling, so that it is clear rather than confusing. You may think, oh, what is this? All of us listen. What are you telling something? So active listening is paying attention, listening to what the other person is speaking, and to listen to them continuously, not interrupt all the time. And also show a positive sign that you're listening. By what? By doing a nod or saying, yes, continue, I am listening. Or by just eye contact. Because if you're actively listening, you'll do eye contact. If you're looking at your mobile, will you do eye contact? So this active listening is very important. And as I said, verbal affirmations, just saying yes, yes, continue, carry on, what more you want to say, something like that. So active listening is very, very important element of communication. Next slide. And next comes what type of question you're going to ask. Open-ended questions are preferred. Why? It enables to get true and detailed response. I'll give you an example. How are you? Or how was your day? That will make them tell more. Oh, I woke up this morning, I did this, or I had this trouble. For example, Telugu, you can, ఈ రోజు ఎలాగుండిందండి అంటే వాళ్ళు ఏమన్నీ జరిగిందో ఆ రోజు అన్నీ చెప్తారు. మీరు బాగా లేదా అలాగ అడుగున్నాను లేదు, ఎస్ నో జవాబే చెప్పేదానికి వస్తుంది. మొదట ఎలాగంటే మీరు ఈ రోజు ఎలాగుండిందండి అంటే వాళ్ళు నేను అని చెప్తారు. సో వాట్ యు ఆస్క్, క్లోజ్ ఎండెడ్ క్వశ్చన్. క్లోజ్ ఎండెడ్ క్వశ్చన్ మీన్స్, oh, is there someone who doesn't know Telugu? Because this batch may have people both Telugu speaking and non-Telugu speaking, I think, because someone has mentioned that.
Yes,
Is
ma'am.
that clear? Is that what?
Yes, ma'am.
That's why I'm telling in English only most of the time, only because I was requested by some of the participants that, hello? So I am explaining in English also. Yes, someone has mentioned. So basically, open-ended question means you will get a detailed answer. If you ask closed-ended question, you will get only an yes or no answer. Is your pain better? Yes, no. How is your pain? What is your response to the medicine? So those type of question, if you ask, so that is why I said, how was your day? Or so your question should be an open-ended question so that you get a better response. And then next important thing is, as I was mentioning about active listening, sometimes remaining silent will also give you an opportunity for them. If someone is upset, you be quiet, be with them. That is more important rather than speaking at that point of time. Okay, so even being quiet may be helpful for you to give them some support and also an opportunity for them to open up and say a bit more. After you give some time, then they will open up again. Next slide, Sinia. Next slide, please. Then what are the skills that we will develop? Clarity. Whenever you speak, not only, see, as volunteers, because when you're going to collect information and give information, both has to be clear. So it has to be simple in clear language. Don't use medical terms because not everyone will know. And next is confirm that the listener understands. That means what? You are conveying some message, you just keep on telling, and after some time we have to ask, whatever have I said, have you understood? Sometimes when you ask that question, they may be blank. So that is why you have to ask that in between and make sure that they're understanding. And if you do that, because it makes us also comfortable that whatever we have said has gone through, they have understood, and they can repeat it back to us. And next is you tell it in the adequate tone and volume so that it goes across comfortably. Next slide. Empathy. What is empathy? It is the capacity to understand what another person is experiencing from within the other person's frame of reference. In simple words, if you say, the capacity to place oneself in others' shoes. So normally sympathy is one, or you feel sorry or you feel compassionate for the other person just by your feeling or response. Whereas empathy is you putting yourself in other person's shoes. If it was you in their place, how will it be? How will the response be? Those type of things is what that response or that quality behavior is empathy. Next slide, Sinia. Team working is very, very important in palliative care. So that is where, as a volunteer, you can be a very important team member. So whenever you work as a team, you have to respect each and everyone equally. And main thing, you have to work together. How? Putting the patient in the center and do everything in patient's best interest. Look at the broad picture. Their individual, my interest is not being conveyed. What I want to do is not done. No, we will not even think about it. Why? Because patient is the point of best interest there. With patient's main goal objective is what we are all going to work together. And in that situation also, you consider the social and cultural situations. That is why, as a local volunteer, you can play a good role. For example, a patient has some specific cultural belief. Being part of that same area, you will understand and be able to express that from the patient's point of view to the doctor or nurse or some other provider who is going to help. So that is where you can be a very important good member of the team providing the service or care. Next slide. How to manage these as a volunteer is what we're going to see next. Next slide. Various aspects of palliative care are there. For example, medical issues, patient care, social issues, psychological and emotional issues, financial shortfalls, cultural and spiritual issues. In all these, how as a volunteer you can help is what we are going to see. Next slide. Medical issues. It is mostly medical professionals, but as a volunteer, what you can do, you can reassure the patients so that they are able to receive and understand the information. See, if, for example, many of your volunteers are well educated, so the patient is not educated at all. They don't know head or tail, diagnosis, everything is blowing like some Greek and Latin to them. So there, as a volunteer, you can be with the patient when they're going to see the doctor and explain things to them, can accompany them if they are comfortable. Again, all this you get permission from the patient and then do. So there you are a very active, supportive member. So that is so everywhere you can be of help. So this is one element. Next slide. Patient care. You can, as I said, you can develop these communication skills and render that as a service to them. Teach patient and carers easy home nursing care solutions. There are plenty. Everything cannot be told in this short session, but I have got one example which we can see. One of that is hand hygiene, which can be taught to them by volunteers. It is taught by nurses and doctors, but it can be done by you also. Next slide. Okay, if you see this picture, it is self-explanatory. Okay, everything is clear in that, but you can, because all what is written in English they may not know. For example, if you see the picture on the left side, it is just how to do hand washing. With COVID gone just few years ago, hand washing is a very important thing, and internationally so many studies have been done which have shown just soap water wash is so much better than even a disinfectant. So if you see the pictures, it just shows where the places in between the fingers, scrubbing the nails, thumb. If you, this is what, so 1, 2, 3, 4 shows that, and then wash it well, dry it. So these are the stages of hand washing. Okay, this we can teach. Why hand washing is important? If you see the picture on the right side, whenever they're caring for a patient, whenever you're going to start providing, when you're going to see the patient, first do anything, touch the patient or do some dressing or change sheet. First you wash your hands. That is for the patient's benefit, so that you don't carry infection and give it to the patient. Okay, next is this next thing is that if you're going to do any, here 5 situations what are given is whenever you need to do hand washing, like whenever you're going to change, as I said, change dressing, or any body fluid like urine, motion, like that, anything you're going to be in contact. After touching another patient, you're seeing this patient, and you also have to the main thing is that this body fluid, any wound discharge, all those situations you do. Finally, you wash your hand. That is, why do you do that? That is to protect yourself. First, what you did first when I said hand washing is to protect the patient from you carrying any infection. You have done all this, and then when you're finishing, again you do hand washing. Why? That is to protect you from not getting any infection from the patient. So these are some very basic things which anyone and everyone can teach. And just normal hand washing. But normal hand washing, if you don't do it properly, especially when you're caring for patient, both, as I said, you can carry infection to the patient. And similarly, if you don't do the hand washing properly after doing something for the patient, you can carry the patient's infection to you. So this can be very easily avoided if the hand washing is done properly. So this can be taught to all of them by anyone. So this is an important, simple thing. As I said, there are very many more things which we teach, like home care measures. So this is something very simple thing I thought can be explained and told. Okay, next slide there. Generally, in care, you have care, compassion, competence, that is the capability, communication we have seen, courage and commitment. See, courage is everyone should come up. See, all of you do have courage to do. That's why you have come up. Otherwise, you could have all sat at home, no? So, and then commitment. Courage and commitment is there. That is why so many of you are attending. So if you pursue and follow this continuously, you will be able to provide the service also. Next slide. Next is social issues. How a volunteer can help. One-to-one, you can have some one-to-one conversation with patient and carers. They may have some issues, some personal issues, or something which they want to share. Many situations, there is no one to listen to them. That is the situation today. They may be 80 and 90-year-old. Nobody else is living with them. So at that point of time, you just go speak to them. That will be like a bumper prize for them, equivalent to winning a lottery prize of lakhs or millions. So like that service you can provide. Look into solutions also with them. Sometimes some solution option also you may be able to give or discuss. When all three of you discuss, something may come up. And achievable solutions is what to be aimed at. Similarly, at that point of view, you should tell something which is possible and feasible, not something may be possible for you, not possible for them. So that's why a combined solution, if something is possible and achievable, that can come out of that conversation also. Next slide. Psychological and emotional issues. It's these managing or dealing with this is a challenging task. So generally what we say, you involve a psychologist or counselors if possible. See, sometimes some volunteers, like today they may be doing something, but 10 years down the line, I also did so. Many people are there like that, who would have done, basically some maybe they have done BSc psychology. After that, I didn't work at all. I did something else. I was a housewife or a homemaker. And then suddenly 55, they decide, oh, I want to be a volunteer. They have their basic qualification of a psychologist. They have a qualification like either a psychologist or someone who has done BSc psychology. Okay. They can play a role of a counselor, or you can work with the psychologist to help the patient. And being empathetic itself, I did mention what is empathy. So when you say that you try to be in their shoes and look at the problem from their perspective, that itself will be of big help. Last but not the least, if you are an active listener and you are silent and help them, just being with them, being quiet with them or listening to them does more wonders than what we anticipate. See, for this, many of us may even be a sufferer, and this one, what I'm explaining, many of you may understand and need no more explanation at all. Next slide. Financial issues. Okay. From financial point of view, carers can play a big role. How? Involving local charity organizations. For example, I'm going to give you some simple example. Then someone needs like there is one family, someone breadwinner is sick. So they have 2 children who need some resources for study. And you also know, being an important member in that area or community, you know someone who is waiting to donate money to someone, but only main concern of him is, I want to give money, but I want to make sure it is being used properly. Many times it doesn't get used properly. So there is, you know, someone is waiting to do charity, and you also know that there is someone needing it. You can be a bridge between the two. So that is something very commonly you can do, either as an individual person, or there are many NGOs who have the capacity to do, and they don't know where to provide that. So linking the NGO and the patient, that is one option. Or you can arrange monthly once some meeting, for example, in the society or in the hospital where there are patients. Find out, like through the month, you collect information and make one event, so that event with the charity and groups in the campus itself. So you, rather than everywhere demand and supply, you're linking both. You can do it as an organized event monthly once or once in 6 months, and make sure that the demand and supply are met and the benefit is obtained for the person who needs it. Next slide, please. Next is cultural and spiritual needs. This is again a sensitive area, and this has to be managed based on the regional needs only. No forcing anything will work there at all. Okay, we have to give due respect for each area's cultural or regional, because that is how they have been born, brought up, lived all their life all along. You cannot suddenly go and enforce anything. So live and do along with the cultural and regional beliefs. Okay. Again, next, spiritual needs, if and when dealt with, give satisfaction to patient. For this, some example based on their religious or spiritual need. For example, if I will give example for any religious person, if you get their concerned, like a guru or a father or preacher or some, whatever their belief, that person to come and do some prayer for them according to their belief and need. They, see, for example, someone might have been a very religious person, going to church every week, or going to mosque, or going to a temple every week. Once I used to go, but now I cannot. For them, what you can do, you can bring, if someone is there, you can bring the preacher to their house, because they will get so much belief, so much relief. So something like that type of help you can do. And those things do help in a very, very long way and large way. Next slide. So this is just said as 7 C's of communication. Whatever you want to say should be clear, correct. You should not give improper information, and as complete as possible. And concrete means it should be to the point. Concrete, concise, nearly the same. It should be definite, clear, and coherent. Don't jump from one topic to the other, or not to say something irrelevant. And last, you have to be courteous. No, like authority, that authoritative attitude will not work. So being courteous is what will be successful. So these are said as the 7 C's of communication. Okay, next slide. So how to be able to acquire these skills? Next slide. By training, that's what all of you are attending today. Retraining if and when required. What happens? Okay, all of you get trained. Some get to practice and do things immediately. Well and good. But some, I did the training, but nearly 2 years, I didn't get any opportunity. I was busy with something else. Then you may need to retrain yourself. when you want to go and start doing it, that time you may need some retraining. And working together as a team. See, one person may be good at one thing, another person may be good. So that you utilize the pluses of team working. And as I said before, also keeping patients' best interest as the point of focus. Anytime in team working, respecting each other and also maintaining dignity of one and all. That is very, very important. Otherwise, the team will collapse and not sustain. So we don't want that happening. So try your level best to maintain and respect each other, and so that you can go ahead. Thank you, dear. We can come out of this presentation so that we can take questions. And I didn't want to break in between because of we were having difficulty in the sharing and things. No, so I'm extremely sorry about it. That we had to have these technical glitches. So now I would say first I'll check the chat box if anything is there. Okay. See, again, all your queries. Who is generally assigned as leader of the team? See, it depends. Again, no, based on the individual patient, or if it's going to be in the hospital. If it's a hospital palliative care team, there the doctor, nurse will be there. Or if it is going to be a home care team, again, home care team, some teams will have only nurse. So, but again, the volunteer, for example, I will tell you live examples what we do. Here, we have some centers which are very rural, where nearly the volunteer becomes a leader, because volunteer will know the location, will know the patient's house, everything. So we will have we will go to the area, pick up the volunteer first. And then the whole list of patients will give. So even if a new doctor comes or a new nurse comes, it's no issue at all, because the volunteer knows everything in the area. Volunteer. So the team leader also can vary from time to time. But again, the main focus or the main objective of the day decides who will be the team leader. Is that clear? Have I answered what?
Ma'am, Roshani ma'am has raised her hand.
Okay, then yes, I was about to say, you can unmute and speak, Roshni.
Yes, thank you very much. I was wondering,
if you don't mind, can you say where from you are and tell a little bit more, and then
I'm Roshni Babu, and I'm a research scholar from Mangalore.
Okay.
So my question was the 7 C's that you mentioned, right? In the communication. So would it be possible for us to have a role play or a video of a role play, or could you elaborate on the 7 C's?
There is we have a video, but that is in Malayalam, I think,
No,
or
ma'am.
English. Let me check. That's English, no?
Yes, ma'am. Yes, ma'am. I'll share it.
Good communication. Can we do? Can we play that now?
Yes, sure. We can play
thank
that.
you.
Just give me
have a
2
role play. Oh, thank you. Thank you for bringing it up. Also, I should thank you also, Roshni.
Ma'am, you can continue the discussion.
Yes, you will get it ready.
Yes.
Okay. So, anything else anybody wants to ask, please ask. Any other queries?
I have one more query, if I'm allowed to ask.
Yes, go ahead. Go ahead, and then.
Sure. So I was wondering, there are certain patients, when they come to know about the terminal illness, they would not want to continue with their medication for various reasons. One of the main important ones being the financial burden that the family is going to face. So in such situation, what do we do? And also, how do we mitigate this one? Because do we coax them or try to convince them, medication, taking medication?
No problem. I will answer that because that is medical ethics. What was you attended yesterday or not?
I did. That is the reason I'm asking. I'm a research ethics student, so that is the
See,
reason
that's
I'm
what.
asking.
So they, so there. If you don't mind, somebody else also was talking in between. May I know, like, is there anybody else wants to ask anything?
I am
Go
Dr.
ahead.
Chalapati, madam, from Tirupati. We wish to start a palliative care center and also clubbed with Aspices in SVRR government hospital, which is serving almost 6 districts of the Andhra Pradesh. Poor people, poorest of the poor will attend the treatment there. And, you know, as usual, as you said, the medical, due to limitation in the curing the disease, there will be some termination at one point by the doctors. So we want to help the poorest of the poor to accommodate
Okay, I think no. So
in the
you want to know
hospital.
how to start? Do you know what? Do you want to know how to start a service? Is that
How to
your question?
organize now
Okay,
to start with.
I think
Involving everybody, doctors and their
that's what.
nurses. They are
That's what. Like,
huge medical technical person are available in the as students, as
one
house
second.
surgeons, as
That's what.
doctors.
Like, I think there was the other person who asked also, no, non-medical person who asked me before.
Prakash Matthew.
So for both of you together, I will answer. I will answer Roshni's thing, and I'll come to you. Okay. From Roshni's point of view, the 4 cardinal principles are autonomy, malfeasance, beneficence, non-malfeasance, and justice. Okay. Your thing comes. So basically, those 4 are: autonomy means per patient or person's decision is final. How it is final? If someone can make the decision understanding everything, then whatever anybody else doesn't have a role there. Okay, as long as they are compos mentors and we have conveyed everything to them. So that is autonomy. So the patient or person's decision is final if they understand everything. If they are not able to understand, they have dementia, they don't know, they are completely off, then next of kin or patient's best interest comes to play. Okay, that is autonomy. So here you said the patient is not willing, means then that is the final only thing there. Our role is to make sure that the patient has understood the pros and cons of having treatment and not having treatment. So it's our duty to explain everything to them, the pros and cons. And after that, still they make the decision not to have treatment. Patient's autonomy is the deciding thing. Nothing else comes to play. Okay. Then beneficence is we have to do only good to the patient. We cannot do any harm by saying that I'm doing good, and in turn we cannot do harm. Last is we should never do harm. That is non-malfeasance. You should not do harm. Our duty is to do good. And then the 4th one, justice, means using the resources justly. For that, yesterday, as the example the doctor gave, no, the ICU, I will give a simple example. You have 2 patients, one 90-year-old patient who has carcinoma stage 4, but suddenly has gone into respiratory distress. Another patient, 20-year-old patient who has been diagnosed recently with pneumonia, who is also breathless, who needs ventilation. Between these 2 patients, for whom will you give ventilation? Who is the best candidate for going into ICU and getting treatment? Anyone can give your idea.
The young boy.
Whoever
why
is
and
admitted
what?
first. Whoever is admitted first.
No.
The young boy,
think,
because we can say
Kishore Kumar.
Yes, ma'am. Yes,
may I know what you do? And
ma'am, I'm a psychiatrist, ma'am.
Okay. And was Prakash Matthew, you said who comes first? Is that right?
Yes, ma'am. Whoever is admitted first.
See,
that's just right?
So that's what. See, that is where see, basically That's why that word justice or justly I said, because between the two, who will have a better outcome? This boy is having a curable, treatable disease, whereas the 90-year-old, whatever you do, you cannot. Something which is inevitable, you cannot change. So at that point of time, you're going and trying and doing something, it will be waste. You're not using your resources wisely.
Okay.
So see, that's what, see, everything justification. Nothing is done because I like, and no one should do that. No one should do with any personal interest in it. So always, that is why in this whole 40 minutes, how many times I've said, patient is the focus, in patient's best interest. Every word counts. All these presentations, all of you will be shared with. So even now you don't get, you see, read, and you can get to know more. Okay. So that is something.
Ma'am, if both are
have
curable
I answered? No, but see, both are this is the example I gave. Both are curable, then you have to see your resources, you will have to see again how many beds you have. In that also, if both are 20-year-old, both need. That's all, simple. See, there's only two ways in it. If both are 20-year-old, both having pneumonia, both need it. There's no discrimination. Okay? Is that clear?
Yes, ma'am. But if the 90-year-olds, that problem is also curable and he also needs ventilation, the 20-year-old boy also needs ventilation, that's also curable.
See, no. See, that is where you're imagining that, whereas medical science and evidence and things show that 90, that is where lack of knowledge, not to get offended or anything. That is where you need expertise. See, for example, you said you're a software. If you ask me about computer software, I am a Buddhu in it. Okay, I will accept that. So someone has to be brave to accept what they don't know.
Okay.
And I won't say that I know A to Z of computer. Okay. And even medicine, I won't say A to Z. But what we say, we have clear evidence. With 30 years of medical practice, 30 years of experience in intensive care, we say this outcome will. And nowadays, not only I say, there is clear, there are scores. There are scores which we will put with patient's age, problem, everything. It will give survival, mortality, prognosis, everything is coming as score. I need not put anything. Everything is in black and white. No one can cross question. So for a 90-year-old, we will show you everything. This is what it is. So then wise decision has to be made. So that is where using the resources properly comes. And that we have to try and justify wholeheartedly. You should be willing to speak the truth, tell the truth, and do the truth, which is very difficult. It's a challenge, biggest challenge. Okay, can we play, if there is I'll check, there's something in the chat box. When we get notes or slides as reference, you'll get these, all PPTs will be shared. Already she has mentioned. Can we play the...
Yes, ma'am, we can play that.
Before
please,
I have
please go ahead.
just one question, ma'am. Is it okay to ask, or later we can ask?
We'll play
related
this,
to the communication.
and then go. Yes.
Okay.
No, we'll play this video and then.
Okay.
Thank you, Sinia. See, like all what we said, explained in that itself. See, the way she sat, introduced and spoke to them, like eye level. Then also, see, the patient was taking medication. But when you ask only, so many things not taking according to the schedule, then explaining to them, and made sure that the patient had. And then next, when he was upset and crying, she quietly listened. And then how did she reply? That's the empathy. I can see that you are, what is exactly what was the trouble. importance of so that was done. And then reassurance. See, as through the talk, I did say physical thing is there, but what was his main concern? He is the breadwinner. His pain, many times what happens, even you will all see that pain, patient will be complaining of pain, but something, see, we have, it's a blessing. I think Reena Sanjay Gupta, no, who has gone through all this. I'm really so grateful. I have no word to thank you, dear, because when you have been on the other end, you will know what it is. So, for example, for this patient who you saw in the video, his family was his concern. Pain. Sometimes they'll say 8/10, but you give medicine, no change at all. So you go on increasing medicine, then also no change. Then suddenly one day you sit and talk more. They'll tell, my main worry is my child. Find school or support for them. Next day, pain from 8 to 2. Same medicine, same everything. How did the pain come from 8 to 2? That's why we say, if you see definition of pain, it has physical, social, psychological, everything. Only when you know about it, you can put only what the brain knows, the hand, eye, everything will think. So like that, it has got. So this patient expressed that. So when that is solved, even his physical pain will come down. You may argue or even disagree with me that it may not come down, but the truth is that. Okay, and then there was a query that importance of silence, Roshan. See, for everything there is no answer in the world, dear. Okay, and there need not be answer for everything. It will be initially very difficult, especially for educated people. It is very difficult to accept that. Slowly, you will know that many times there are no answers. Even in science, research, everything. Is there an answer for everything? Not in a bad way. But I don't say that you're stopping science and research because of that. Some things may not win. We have so many autoimmune diseases for which COVID itself is an example. So nothing wrong in not having answer. So in those, and why silence? See, for example, when patient cries, why is it me and why? So sometimes keeping quiet, no, they themselves will figure out what it is. That is where silence speaks. I don't know whether I have justified or answered what Roshni Babu's answer, but to what extent possible, I've said. And Prakash Matthew did say that he had a question with communication. I'll read. What to speak if the patient is not willing to open up even with the recommended good communication? How to communicate with patient with aggressive behavior, asking me to get out. Okay, so for those two, for the first question, what to speak if the patient is not willing? Initially, first contact or first meeting, 8 out of 10 will not open up. Okay, we don't expect. So that is why we say in the beginning, what did I say? These are sensitive special issues. So you may need to have like meetings or appointments few times, especially these type of things. 1 meeting, 2 meeting, no, 3, 4 meetings you may have to do to gain confidence. Only if they have confidence and rapport, they will open up. Not only patient, we also will not open up. So we have to understand that and give time and space for them. You keep on telling the information slowly, peacefully, and then one day they themselves will open up and come and tell you. That is the answer for the first question. Second, how to communicate with patient with aggressive behavior. Those type of things, you will have to, like, there is something called as anger management and all. You have to save yourself also. So be polite, make sure you protect yourself in those type of things. That's why we say like that. Even when you're having you leave the door open. We teach all this also. Sometimes leave the door open and you don't make sure that someone attacks you or something like that. You just tell them you are not forcing anything on anyone. Okay, so that is what is important. So if it is an aggressive behavior, you have to make sure that you are safe and the patient is safe also. Many times there is something called as denial. Everyone knows, but they don't want to accept. And that is a common thing, especially when someone has a life-threatening, life-limiting illnesses. It's a behavioral change. Denial is very, very common, very important in these type of situations. But breaking that denial phase again will take time. And many times what happens, they will keep on denying. For example, accepting. For example, many times in between spouse, husband, wife, someone is very ill. It's a way of showing love and affection is when denial increases more and more. And in that also, if you spend time and do some counseling or something like that, they will be able to understand. And then slowly, if there is no aggressive behavior, you can slowly tell them. And then one day they will accept. And we have to tell them, these are the plus and minus of you avoiding or not doing what is there. Then day one, they may not accept. And many times, even when they sit and think by themselves, they may accept and slowly come back and agree to your terms and conditions also. Patience, repeated meetings, repeated discussions is what will help. And sometimes you may be able to find out through psychological counseling and things, what is the reason for their underlying aggressive behavior. Mostly we can find out. That's what psychologists do. Okay. I've seen all the there's no more question or anything in the chat box. Is this training provide certificate? Yes, I think you will get a certificate. Is that right, Sinia? They will get a certificate.
Ma'am, those who attend like 4 sessions will be receiving the certificate, at least 4 sessions.
You have to attend 4 out of 5 sessions.
Yes.
Is there anything else you want to ask regarding Prakash and somebody else's question of starting a palliative care setup? No, in short, in like 2 to 5 minutes, I'll tell you. First, you need doctor, nurse, and social worker. All 3 of them you need, at least 1 each. To run a service properly, I would say at least 2 each, because anyone you pick up, manpower also you have to. Everyone can have ailments, some personal issues. You have one person running the show, fatigue, burnout, all that is there. So in that aspect, I would say 2 doctor, 2 nurse, 1 or 2 social worker. 1 doctor, 1 nurse, 1 social worker is the basic skeleton needed to start a service. And if you want to start a service, if it is a hospital setup, we would say normally start with the outpatients, and then slowly see in 1 or 2 months how many patients you're having, then add on inpatient and add on home care. Okay, that is the general setup. For all this, Pallium India will help you, because we have regional coordinators. We have regional coordinators for all 4 corners of India. South, north, east, west, everyone. We have 4 regional coordinators. We can link them to you, and that can be done. And regarding Prakash's question of home care, you can do home care service. For that, you need a nurse, at least 1 or 2 nurses trained in palliative care to help and take it from there. Okay, and I think this Aravindan is the person whom I said I'll talk to them yesterday. So they said they are some group of 10 people attending. Are they still there, or?
Good evening, ma'am. Yes, we are here.
Your name is Aravindan, right?
Correct.
So maybe because we are running out of time, can I talk to you tomorrow?
Sure, ma'am. Sure. Whenever you are free.
So that's what I'll talk to you tomorrow, because anything you would like to get or know can be seen. See, main thing, don't think I'm not a doctor, I cannot do anything. No, we have 3 more sessions. We have where so many volunteers play such big roles in Pallium.
Sure.
You have a session on it. So first, all of you, you've all got some good intent in your heart and soul. So good, when there's a will for good, good will happen. All of you will be able to do something at some level and move forward, and you can reach very high levels also. So have that in mind, and the rest of the 3 sessions, you will see more about how volunteers can help. And
Sure.
okay,
Yeah, thank you so much.
and we will share that if anyone is interested, get in touch with Pallium for starting up services and things. And Dr. Someone who wanted to start the service in Tirupati, is he still around? No, I think. Okay, we have said whatever. Bharati madam, can you pass on the message to the person who asked about starting the service?
Yes, madam, he is there.
We are all here, madam.
Okay,
We wish to start as a group, madam. Bharati madam is our leader.
So that's what. So basically, what I have said only you have to follow, and you can get the help of Pallium. Pallium will handhold and help you. Important thing is training. Doctors need to do foundation care program training for doctors. Nurses have to do their nurses training, and this is exclusively for volunteers. So this training will not be sufficient to become a doctor or nurse trained person in palliative care. But everything is available online also for you, and hands-on also is needed. Just online alone will not give you confidence to start. Okay. So the rest of the days will help you more, and I think that should be helpful. What are the rest of the questions? The videos can be, if they can be shared, they can be shared, Cynthia. Do Pallium India regional coordinator support only NGO, or do we support anyone, everything?
Can you mail to our mail IDs, madam, these lectures? Today's matter, can it be mailed to our mail ID?
Every day, our IT team will communicate with you and send you all 5 days material will be shared. And Pallium, one of the questions, Pallium helps everyone. Only NGO, government, private, anyone they will help. We have no difference. Dr. Rajagopalan's main aim and goal and vision is for palliative care to go to all nook and corner of India. Okay, so no, we are ready to help anyone and everyone, and no match. Pallium does it. I am a small, like what to say, I'm the smallest particle there. That's all. But there are big people who are willing to do more. And Pallium is willing to help. Okay. In that case, I'll pass it over to you, Sinia.
Thank you so much, ma'am. Thank you all for joining for today's session. We will be having the session on psychosocial care tomorrow. I will see you on the next session. Bye.
Thank you, one and all.